Good evening once again, everyone. Welcome to another Sunday of AfroDX, where you get to learn some interesting facts of internal medicine and in a while, enjoy the learning. So, David, I've got a cool case for you today. And before delving into the case, we should remind everyone here that the cases we present here are real cases, but we change some information so to protect the privacy of the patients that we are using them to learn here. It's the purpose of learning. So what we have today, David, this was a 71-year-old male who was admitted in my hospital with a complaint of abdominal distension for 2 months. And he said that 2 months ago, he started to notice abdominal distension, which was gradually increasing over time. Initially, it was painless, but over the past few days before admission, he started feeling pain. The distension was associated with early satiety, nausea, weight loss, and night sweats. He denied vomiting at that time, constipation, hematemesis, melena, lower limb swelling, shortness of breast, joint pain, skin rash, hair loss, or fever. If you have other system, no augmentation, no numbs or paresthesia. Past medical history, he had hypertension, diabetes, GERD, bilateral knee, osteoarthritis, and chronic low back pain. And here are the meds that he was on: Temistatan H, amlodipine, metformin, glimepiride, glucosamine chondroitin, esomeprazole, Resagel, pregabalin, tizanidine, and tramadol as needed for pain. Family and social history: he was married, he had 5 adult children, he was a retired medical doctor, didn't smoke, and he said he used to drink a glass of whiskey on most day of the week for many, many years. And yeah, that's it.
Okay, let's see where this goes. So you already said it's a long case. I think I'll also try and make sure that I am brief. Abdominal distension, a 2 months history of abdominal distension. So to start, when I hear abdominal distension, my first thoughts are what exactly is the cause of this pain? And of course, we use the same mnemonics, which I believe are very famous. Talk of the 6 Fs. So I'll exclude one F for him. He's a 71 years old male. Therefore, we are not going to talk about fetus. So the others, we are talking of fluid. We are talking of fat flutters, and then uh, I already said I'm removing fetus there. So the other one is when there is a fetal growth. So that's like when there is a neoplasm. So I think I mentioned five. I'll try and see what. So there should be five. There should be six actually. So he has presented with abdominal distension for 2 months, which is slowly progressive. I'm not going to discuss every bit. So initially it was painless, but later on, so the early satiety could be due to a number of things. The early satiety as well as particularly the early satiety could be that this patient is inflamed, which I cannot rule out because the patient has weight loss and night sweats. So I think for that I'll consider a possibility of inflammation because there are night sweats as well as weight loss. But the early satiety could either be because of the ongoing inflammation or the early satiety could just be because of pressure symptoms. So when someone has massive ascites, for example, or any other growth that is compressing the stomach, you'll definitely feel full earlier as compared to when there is no distension. So uh, absence of vomiting, absence of constipation, particularly. So I talked about fat and so feces and flutters. So absence of constipation, if the patient is having normal bowel habits, that means, and of course, talking about intestinal obstruction, for example, for a period of 2 months, if it was complete intestinal obstruction. So this patient would most likely would not be around. Hematemesis melena, the absence does not rule out portal hypertension, for example, which could be one of the causes of abdominal distension for this patient. And then the patient does not have shortness of breath. So yeah, commonly we would expect if there is shortness of breath, we would want more qualification if there is shortness of breath on lying flat in order to establish if this patient has heart failure. But shortness of breath not present as well as lower limb swelling, likelihood of those issues goes down. So rash, hair loss, especially with connective tissue diseases, autoimmune diseases in general, they are not present. So up to this point, I think I have just excluded a few things. So as I said, fetus, of course, we cannot talk about that. Intestinal obstruction, so feces and flatters, we can throw those away. So fluid is a huge possibility, and fat, it's not common for someone to become obese and not notice that they are obese, and then they come complaining of abdominal distension. So that's less likely. So I think a huge possibility here is fluid. But another possibility that we are remaining with, which we have not been able to establish, is a fatal growth. That is, the patient is having an intra-abdominal process, something that is growing and presenting with these symptoms. So those are my thoughts for now. But coming to review of systems, I do not see anything significant. So the hypertension, a history of hypertension, you would think, okay, hypertension, if it has been there for a while and not well controlled, it could end up with heart failure presenting with abdominal distension. We have not seen other features of heart failure in this patient. Diabetes, a number of things here. So if the diabetes is not well controlled, uh, the patient has some form of immunosuppression, and therefore, because there is abdominal distension, there are night sweats and weight loss. uh, Once we establish, so we'll wait and see what happens there. So if it's fluid, we'll go on and discuss the differentials, narrow down the differentials to fluid, and therefore talk about those differentials where TB peritonitis is one of those things. But diabetes in general uh, lowers the patient's immunity and therefore predisposes them to some issues, including the tuberculosis that I've talked about, and other processes which can present the same way. So coming to medications, so I see antihypertensives there, or hypoglycemics, and then some supplements for the osteoarthritis, PPIs, and then antacids, so pregabalin, tizanidine, as well as tramadol. Nothing rings a bell up to this point. So let's just, there's one more issue. So whiskey, you talk of whiskey is hard liquor. So a glass, we are not sure of the volume, but very likely that this is a significant, uh, that this is so beyond the minimum that we are talking about. And of course, we know up to this point that we know that there is no safe level of alcohol. But then uh, with whiskey, it's very likely that the concentration that the patient was taking is beyond the limits that we are talking about, and therefore I will keep that in mind. So let's see a physical examination.
Yeah, thank you very much. That's several pages of Atchison summarized in 5 minutes. So here's a general exam. He was alert and oriented. He was not in distress. He had temporal wasting bilaterally. He was febrile, not pale, not jaundice, no lymphadenopathy, no lower limb edema. His vital signs were within normal limits. Systemic exam, per abdomen had a distended, uniformly generalized abdomen, which was non-tender, and no organomegaly or any mass palpated. Liver span wasn't done. There was a dull percussion and a positive fluid thrill. The examination of the chest, CVS, neuro were all normal.
Okay, so this is as we said earlier, it's very likely that the cause of the distension is fluid, and that's what we establish here. So, Joseph, did you say you were not able to determine the liver span?
Yes, I didn't do it.
Okay. But also you could not feel in these are limitations. We should know that physical examination has limitations. So with fluid thrill, a grossly distended abdomen, dull percussion all over, so that is grade 3 ascites. It's difficult to appreciate most of the issues. So this patient has grade 3 ascites. Now we have narrowed down from abdominal distension to talking about ascites. Now when we talk of ascites, so that is fluid. So with fluid, the cause can be anywhere. This could be the kidneys. We did not hear, and I do not remember hearing about issues of urine output, whether there was reduced urine output, fourth urine, facial puffiness, or anything. But so could be the kidneys, uh, could be could be the kidneys, could be the liver, and yeah, the liver in general, and then it could also be the heart, which we cannot rule out, although cardiovascular system examination was normal. So with the cardiovascular system, for example, because if someone presents with ascites and we think that this is coming out of the heart, so we are talking of congestive heart failure, would expect lower limb swelling, that is lower limb edema, would expect maybe tender hepatomegaly and then raise the JVP. Cardiovascular examination is normal in this patient, but completely rule out we cannot completely rule out a heart pathology, because we've heard about issues like endomyocardial fibrosis, which can present with a presentation that is very confusing for something coming out of the liver. But then the ascites can be due to any of those things I talked about. I say the heart, the liver, the kidneys, but it can be local causes, that is peritoneal causes like TB peritonitis, peritoneal carcinomatosis. Considering that this patient had weight loss, night sweats, we need to entertain all these possibilities. So another thing is, well, it could be portal hypertension, which can be pre-sinusoidal, sinusoidal, post-sinusoidal. But then I'll just say that up to this point, we've narrowed down from abdominal distension. We are talking of ascites. Now, what exactly is the cause of this ascites? Hard to discuss in detail. All we can say is let's explore inflammatory causes of this ascites. Why? Because the patient presented with night sweats, presented with weight loss, and then the abdominal distension. And therefore, when we think of those inflammatory causes, we'll need to consider infections. And if we consider infections, TB comes high on the list, uh, given base rate. So it's a very common infection in our setting. So I'll say TB is one of the common ones that we need to think about. And then autoimmune diseases. Autoimmune diseases, I mean, isolated serositis, that is isolated ascites as a presentation of serositis. So given the fact that is male, because autoimmune conditions that will present with ascites, commonly you talk of SLE, of course rheumatoid arthritis can also do that, and a few others, but then we do not see a typical presentation of those connective tissue diseases. And then another one is a malignancy, like so a malignancy originating anywhere but seeding to the peritoneum, leading to this massive ascites. But then so it's difficult to move beyond there. So what will help is we need to see, we basically need to tap. And because this patient presented with in the later period of this presentation, initially it was painless, and then later on it became painful, and therefore I think we need to entertain a possibility of spontaneous bacterial peritonitis, which we'll see more commonly when it's originating out of the liver. So when it is related to portal hypertension, to be specific. So Joseph, I think what can help me make progress, and I know we have limitations most of the times, but it can help. We need acidic fluid analysis and then some other labs. Of course, plus imaging, those can help make some progress. So let's proceed.
Yeah, sure thing. Let's see. So here are the labs. The CBC was normal, elevated ESR of 54, urinalysis protein plus 1, leukocyte plus 1, glucose plus 1, RBG elevated 15, A1C of 11.3. The lipid panel was normal, liver enzymes were normal, renal functions were normal, alpha fetoprotein CA were normal, 2H pyrrole negative, stool analysis no parasite over which were seen, stool for cut blood was negative, hepatitis B and C and HIV were all negative, moderate hyponatremia of 124, mild hypokalemia of 3.4, calcium which is normal, chloride normal, albumin 3.8, serum amylase 88 normal, and I'll give you the ascitic fluid. The appearance was clear. The lab said they saw gram negative rods, and the glucose was 25, albumin 3.06. Abdominal ultrasound, only ascites which was seen. Other findings were within normal limits. And patient came in with a CT, so which showed it was a contrasted CT, abdominal pelvis, severe ascites, multiple renal cyst bilaterally, and a thickened peritoneal wall.
Okay, thank you, Joseph. So I'll start with this. So ESR is elevated. Uh, we suspected that this patient is inflamed, and an elevated ESR confirms that. A urinalysis, protein plus 1, leukocyte plus 1, well, not very much. This patient has diabetes, is diabetic, and with poor glycemic control, we can see that the glycated hemoglobin is 11, and then RBG is 15. So seeing glucose in urine is not surprising. The protein is something that you need to repeat again. So one of the things that we can blame, although we should not fall prey to premature closure, is we are not sure for how long the diabetes has been there, but this could be a presentation of diabetic nephropathy. Although many other possibilities are also, we should be open to those. So the patient is inflamed, poor glycemic control, and the urinalysis is, he has an active urinalysis, some proteinuria, leukocytes, and glucose. So the liver enzymes particularly, we have normal liver enzymes. So AST, ALT, GGT, all of them normal. Yeah, so another thing, creatinine, so we were talking if whether this is coming out of the kidneys. So what we would say if this was a kidney issue, you can have a normal creatinine, but then we would have nephrotic range proteinuria, and then we would have hypoalbuminemia. But the serum albumin is normal, creatinine is normal, BUN normal, the protein not nephrotic range. So up to this point, what we can say is that the liver, it's very likely that the liver is paired because we can see that the liver enzymes are normal. We do not see hepatocellular injury. We do not see even a cholestatic pattern. And then the albumin was also normal. So even synthetic functions of the liver are normal. So we should not assume whether this is whether this is portal hypertension or not. So we have the serum albumin, it's 3.85. Joseph, show me the ascitic fluid albumin, 3.06. So 3.85 it was, right? Yeah, so if you take 3.85, 3.86, and this other was 3.06. So if you minus, that is 0.8, right? So 0.8 is less than, that is less than 1.1. So if it is less than 1.1, then we are not talking about portal hypertension here. It's not due to portal hypertension, because portal hypertension, if it was a transudate, would expect the serum to acetic albumin, serum acetic albumin gradient to be more than 1.1. So in this patient, it's 0.8, which means we are talking of a local cause, and therefore, whether it's periportal fibrosis, whether it's chronic liver disease, and of course, we've seen that the liver is spared. Triple serology, I believe it was negative. Uh, and so Joseph also did amylase, and someone would wonder, why do we do amylase? So another thing that could present with ascites is when you have pancreatitis. So pancreatitis can present with ascites. The amylase there, I believe also lipase, all those other things are normal. So this is a local cause. And what confirms that this is a local cause, imaging CT reported thickened peritoneum, so we know that something is ongoing there. So these are the labs. Can I see the next ones? Okay, so thickened peritoneal wall and then multiple renal cysts bilaterally. So I think we would it would be helpful to get more description of these renal cysts, because if they are small, uh, thin-walled, they are not complex, then we would not be very much worried. Although we would need to know how many cysts, but then we would not be very much worried. But then if they are thick-walled, if they are complex, then we should ask, because even renal cell carcinoma can present in a cystic fashion, but then being bilateral, that also uh, it's not very likely for someone to present, if it's something malignant, to present bilaterally at the same time, unless if it has spread, and then in that case it wouldn't be cystic like this. But then what I take from here is that you have a thickened peritoneal wall, elevated inflammatory markers, that is ESR, and then an uh, exudative ascites, and therefore that makes me think of local causes. And therefore, if we think of local causes, let's talk about peritoneal tuberculosis and peritoneal carcinomatosis, or something primarily originating out of the peritoneum, that is a when you talk of something like mesothelioma, I believe it would also be called a mesothelioma, because it comes from uh, a, uh, a peritoneal surface. So I think up to this point, my thoughts are local peritoneal causes, and therefore, if it's local peritoneal causes, those are the possibilities that I'm thinking about. Although I should admit that I think I'm limited in the number of differentials that I can think about, but those are my thoughts up to this point. So, Joseph, I think something else that I would do for this patient, I would do, although of course the yield is not very much, but then in our setting we should make some effort. So do gene expert in the acidic fluid, although it may not be very helpful, the yield may not be that much. But another thing is acidic fluid adder. So I would need those things. And then, of course, something else that can be done is biopsy. That can help us make some progress. But Joseph, any other pieces of information that you have? Let me see those.
Okay, can you hear me, David? I lost my internet at one point.
Yes, I can hear you, Joseph.
Okay, let's progress. So yeah, we admitted this patient, and yeah, we were sending those tests out and stuff. And 1 week passed, the abdominal pain and nausea worsened in the ward, and he started vomiting everything. And there was a rapid rate of abdominal distension despite repeated taps. So we tap like today, 2 days later, the abdomen is full again. We tap again. And there are some other labs that we sent out. And here's the further acidic free study. Acidic free data 5.2, normal range. Cytology, we sent it 2 times. We sent it once, it comes back, and then we sent it again. The results are the same, that there was numerous lymphocyte admixed with mesothelial cells, some of which are reactive. There was no granuloma, no malignant cells, and conclusion in both reports is that there is non-specific chronic inflammation. And this is the end of the case.
Okay, if that is the end of the case, Joseph, I do not think I'll get the diagnosis right. So there's something that is of concern to me here. So this patient, abdominal pain worsens. We said uh, that it's based on what we've just seen. It didn't look like we are dealing with portal hypertension because of the low sag. So we thought of local peritoneal causes, and so the worsening of abdominal pain as well as nausea. SBP is something that the way I think about SBP is that mostly in those patients with acidic, that is portal hypertensive in nature, that is when we see commonly spontaneous bacterial peritonitis. But then, so I think I'll have to go and read more that if we can see the same even in local peritoneal causes. But I think I'm banking more on local peritoneal causes, and therefore the fact that we see rapid abdominal distension despite the fact that the patient is being tapped. So that means the rate of production of the acidic fluid is that much, and so that can happen. Uh, I think malignancies will do that, but then what we are seeing here, which I did not discuss initially, was that so a few patients that I've seen with malignant ascites, it would be hemorrhagic in some of those. Although I believe it's possible to have malignant ascites and it's not hemorrhagic. So the abdominal pain that is worsening, that makes me think maybe, of course, we also need to treat this patient as we need to treat as a peritonitis because that is the closest thing that we have. But then let me see the next slide. So acidic fluid data is within normal limits. So if acidic fluid data was above 40, for example, would say confidence in TB peritonitis goes high. And then cytology reports lymphocytes, mesothelial cells, and then so some of which are reactive, no granulomas, no malignant cells, and then non-specific chronic inflammation. So this is what I'll say that for biopsy. Uh, okay, so because when you talk of granuloma, I believe that biopsy was taken, Joseph, if I'm correct, because you cannot see granulomas on just fluid. Was a peritoneal biopsy done?
No. It is just the fluid. They just reported like that. So that's what I'm putting it here.
Okay, so I'm not sure how that is, because in order to see a granuloma, you need something solid. So what I would say is for this patient, if a peritoneal biopsy was not taken, we need peritoneal biopsy in order to establish. I think so. For me, my thoughts are still the same. So at this point, I think let me go back and try to represent this problem and see what I can come up with. So Joseph has been presenting a 71 years old male who is a known patient with hypertension and diabetes, bilateral knee osteoarthritis, and then he has chronic lower back pain. He presented with a 2-month history of abdominal distension, which was initially painless, but a few days prior to presentation, it became painful. And this is associated with some constitutional symptoms. We see night sweats and weight loss, but the patient doesn't have fever. And then some symptoms that we can say they are pressure symptoms or inflammatory symptoms like nausea, and then later on he was vomiting everything. Physical examination, uh, apart from grade 3 ascites, nothing else, and wasting, nothing else was reported. And then coming to labs, so he had an active urinalysis with protein plus 1, glucose plus 1, and then leukocytes plus 1. But then significant findings were an ESR of 45. Liver function tests, liver enzymes were normal. So imaging, particularly imaging, reported a thickened peritoneum. And then these are the results for, so for peritoneal, so for acidic fluid analysis, we saw that it was exudative rather than a transudate because the SAG was 0.8. Yeah, so given that, my thoughts are this patient is inflamed, and so TB peritonitis is still a possibility for me. I'm not throwing it out, although yeah, I think I'll need to learn more on the yield of acidic fluid ADA, because in this patient it was normal. Of course, I think conventional wisdom is that if acidic fluid ADA is that low, then your confidence in TB goes down. But then, so further efforts that I'll make, although I understand that we have limitations when it comes to sampling, but I think a peritoneal biopsy is important in order to come with conclusions. So I think TB peritonitis are on the list, and then malignant causes. I have to consider malignant causes. We are seeing mesothelial cells there. We are told that there are no malignant cells, but I think we need to take biopsy and establish what is going on. Now, if it's not an infection like TB, because yes, there are many other infections. So that's just an umbrella. There are many other infections. Given the fact that this patient has poor glycemic control with a glycated hemoglobin of more than 11. So this patient is immunocompromised, and therefore TB is one of the possibilities. If it's not tuberculosis, I know that there are many other infections, including fungal, that can present in these patients. But of course, one of the closest ones that comes to my mind is tuberculosis. So another thing is malignancies. As I said, it could be primary or could be peritoneal carcinomatosis. But then what is against it is that, of course, cytology itself tells us that there are no malignant cells. It wasn't hemorrhagic, although that does not completely exclude it. So an infection, a malignancy will be high on the list. Uh, any autoimmune issue, I did not see another presentation that would point to a specific autoimmune condition like SLE, for example. So, Joseph, I think those are my thoughts for now, and I think the likelihood of missing the diagnosis here is huge. But then, what would help me make some more progress would be biopsy. If we were in a position to do that, maybe that would help me make some progress. So I'll just stop here and then sit back and learn from you, Joseph.
Yeah. So thank you very much. I think me and my colleagues were taking care of the patient. We were in the thinking in the same line, and it was so hard. I'll share the case resolution, and the teaching points will be included in it. And yeah, thank you for keeping the time. I think we're within time. So as you clearly said, a SAG of less than 1.1 means no portal hypertension, and likely this is a peritoneal inflammation and infection, autoimmunity, cancer. There are differential diagnosis. So TB in our setting of crucial importance. Autoimmunity, less likely, nothing else, 70 years male, less likely. And then cancer. So we remain with infection and infections such as TB and cancers. But that that CT result, it was read by 3 radiologists, and they all said the same. They said they are seeing a thickened peritoneum, and they even suggest that we start anti-TB in this patient. So we also thought this is peritonitis, and we put it up there. We wanted to initiate anti-TB, but the patient said no. Uh, get we should wait for the tests which are going to India. That was ADA. So ascitic ADA came back, and it was negative. And I read that the sensitivity of it is 100%. Okay, it is one systematic review that I will share with you, which shows it 100%. Others are saying also 97, 98, very, very high. And that means you should respect it. And so we say this negative ADA, not really. And the patient said, it is saying negative, I can't use anti-TB. So it was like we were stressed to say we have to find another diagnosis. So we said we should rule out cancer, and that's why the differential diagnosis for cancer remains two things. If someone has a exudative ascites, one is peritoneal carcinomatosis, as you're saying, and the other is Kyler's ascites from lymphoma. And it was not Kyler's. Kyler's is something like milkish. It was clear. So this cannot be lymphoma. Say maybe it's peritoneal carcinomatosis. So let's send the ascitic fluid for cytology. That's why we did it twice. We wanted to be sure, but they are both negative. But remember, as we also read, it doesn't rule out cancer. The sensitivity is low, and it depends with a lot of things, the quality of the sample. I read that some other in other hospitals in the West, it's the pathologist who comes at the bedside, takes the sample, fixes it on the bedside, and takes it to the lab, which we can't do. I don't know if what is fixing is, and the cause of malignancy also comes into play. The number of samples that were processed. This was just single, and then the other, which was 2. So the person who did the first physical exam when the patient was admitted repeated the physical exam a week later, and now there was new findings. There was epigastric tenderness and something like a mass that was felt on the epigastrium. And then we said we should dispute the CT. CT showed a 3.5 centimeter gastric mass on the lesser curvature arising from the incisura angularis. We did an OGD, which showed a normal gastric lining, but a mass was compressing from outside. So they also ordered, that's another hospital, a third CT, which showed a pancreatic tile tumor. Sharing this later because it would have been confusing if I presented to you, David. Wanted to learn some things that I think you have clearly discussed. So the final diagnosis was a pancreatic cancer with a peritoneal carcinomatosis. And the surgeons who were seeing the patient, they say that tumor is non-operable, and patient went into palliative measures. So not much teaching points apart from what I have talked about. I had to fetch that meta-analysis which said 100%, and here it is. This is liqueur metal. So this is important because it's the one which is being cited by the American Society of the ATS, American Thoracic Society, Infectious Disease Society of America, and CDC. They put their recommendation that ADA should be measured if you're thinking of pleural, peritoneal, CSFTB. And they cite that paper, which is very important. But there are other papers that show also very, very high sensitivity. And sensitivity, it means if it's high, its chances of ruling out a disease, they are very, very high. If you say 100, for example, it means a 0% of false negative. And then they don't mention serum ADA, which in this country, I see that we do. I see patients that have serum ADA, which means maybe we should stop, or if maybe you have a reason, but serum ADA, no. Yeah, so that was the case. I have my reflection, David, before you. So I increasingly over years learned that diseases, they do evolve, especially for us who are sitting in centers that patients come for the first time. Some people are sitting in tertiary hospitals. For example, this patient, we referred him into a tertiary hospital, and maybe those guys who find it easy. So this is a tumor. Why are these guys wanahangaika? And but if you're sitting in a you are seeing the patient for the first time, they do evolve. So don't feel bad if you miss. You have to repeat stuff, which that was I also learned in this case. And then it's usually taught in medical school and everywhere that in every round you do physical exam, you update it. But I personally have been the victim of this. I don't do it. It's the other doctor who did it after a week, and then we also had a chance to order another CT. So I learned that it's very powerful. You do physical exam in every ward round. Focused. That patient came in with crackles. How about today? 2 days later, we are treating pneumonia. And then at one point in our discussions, doctors, some of us were saying, yeah, ADA is negative, but disease don't read books. Even if it's 100% negative, let's start on TTB. But I usually say that shouldn't be the first thing. The statement that disease don't read books should be the last weapon, like saying, okay, the books are saying like this, and we are seeing differently. We think the books are right, so let's go with the books. And at last, maybe we don't have anything else, we can opt that these don't read books and do our common sense and experience. Yeah, so that was the case, David. Nice discussion.
Uh, Thank you very much, Joseph. This was a roller coaster. So Hassan has a question here that was it possible? Is it possible for massive ascites to obscure the CT finding? Well, I'm not very sure about this. I believe a radiologist would have a better explanation, but well, even with massive ascites, because the peritoneum is so the ascites collects in the peritoneal space, and these organs, of course, including the pancreas, including the stomach. So this fluid will mostly, because if it's minimal fluid, basically it collects around some areas like Morrison's pouch. That's where they see it. So I do not think I do not think, and this of course is based on my limited knowledge of radiology, uh, that uh, that massive ascites could obscure the CT findings. It was probably because of maybe the muscles too small, or the one that read it maybe focused on the fluid and other details and missed that one. Because if fluid was collecting uh, very fast, I believe even when the second or third CT was done, the patient still had fluid, but they were able to see. And I think this is where we get a very important lesson. And Joseph already said this. Let's acknowledge one fact that we are humans, and we can miss things. So our knowledge is limited. uh, Physical examination, a spleen can be there and you miss it. So there is sensitivity even in physical examination, like the sensitivity of palpation to picking a splenomegaly, for example, is around 60%. So you can miss physical findings, and the same applies to investigations. Even radiologists, they can miss a finding, but then, and that is why we say that the diagnostic process is an iterative process. So in iteration, what you do is you you are solving a problem, you have some pieces of information, you collect as much information as you think is helpful for that time, and then you try to solve the problem with that information. And then, of course, the solution is getting the right diagnosis, but then you fail, you go back to the drawing board, see which pieces am I missing. So it's an iterative process, and it can happen. It happens with clinical diagnosis, that is in history and physical examination. It happens with labs, happens with radiology, and even with pathology. So if you send this patient to radiology with a specific history, it might be easier for them to get a diagnosis than if you send without history. So it's an iterative process, and therefore I think that's the issue. And then Antimony is sharing some issues here that massive ascites peaks contrast and therefore limits our visualization of a small tumor. So thank you very much, Antimon, for the additions. Based on this case, Joseph, uh, so basically for me it solidifies that one thing that I've come to learn, that clinical reasoning, what we do is something that sometimes you get right on the first try, sometimes you have to come back multiple times in order to get the diagnosis right. And therefore let's not give up when you, as Joseph said, let's not give up when you when things do not make sense, and therefore you try to grab whatever is the closest, like saying, for example, this is tuberculosis, and then you treat the patient for with anti-TBs for maybe six months. The patient is not responding. Of course, it was unfortunate for this patient that the malignancy was not caught early, which is very common with pancreatic malignancy. So many times I think I am yet to hear of a patient with a pancreatic tumor. This is my personal experience. Most of the patients, I should say, all of the patients I've heard about with pancreatic tumors, they are non-resectable. So it was unfortunate for the patient. But then a lesson that I take from this is we should try as much as possible not to fall prey to premature closure, because yes, as I said, my top two differentials were an infection where TB was high on the list, and then a malignancy with peritoneal carcinomatosis. So for me, I think the way out would be peritoneal biopsy, which probably would be is not very feasible, especially in many of our settings. That would help make quicker progress. But then, even if that fails, grabbing a diagnosis of tuberculosis and saying, let's give this patient anti-TBs and then stop looking, it would take a long time not to get a diagnosis. And then once the diagnosis is established, maybe 5 6 months later, then the clinician would feel guilty that I closed the case prematurely, and then maybe would have caught the malignancy earlier, which was in the case. So let's just remember that the diagnostic process is an iterative process. You need to go back and forth a number of times for some cases before you get the final diagnosis. Uh, Regina is asking, curious about the abdominal pain after 1 week. That it's very likely that SBP could be the case, but the acetic glucose levels were rather low. What they reported, Joseph, I think it was predominantly lymphocytes. Did they report any polymorphonuclear leukocytes?
No, but yeah, thank you, the person who asked the question, Regina. Thank you, Regina. They didn't report the PMNs, but um, I usually think of SBP as the complication in cirrhosis, and there is a cool mechanism for that from the liver, the translocation and stuff. But maybe you can fact check me in the chat GPT or whatever. But I don't know if it happens in other forms of ascites. I've yet to read that, but this abdominal pain was epigastric, and the tenderness was on the mass. I also palpated there. So it was the tumor itself that wasn't palpated initially, and then a week the growth was so fast, it is being palpated and so tender. Thank you.
Thank you, Joseph. Those were my reflections. Overall, I think it was a challenging case to the ones who attended it. Of course, to me also, arriving and That's why I think I did not pinpoint one particular diagnosis. I had two, basically two big umbrellas. So uh, very challenging case. Thank you very much, Joseph, for sharing. I think we still have some minutes. Luckily, therefore, if anyone would like to share any experience, or if you have questions, comments, anything before we close, I think we still have like 5 minutes. So you can just unmute and speak. Antimon, you were active in the chat. I'm not sure if you have anything to share. If you have, you can just unmute and speak. But if anyone else has anything before we close, you're very welcome. Yeah, I'm not seeing any hands. I'm not hearing any unmuted speakers. Maybe there's nothing from the floor. So Joseph, is there anything else from you?
No.
Okay, so if there's nothing from anyone, just some reminders. We probably have other people who are joining for the first time, because I shared with some new people what we are doing, and so it's very likely that we have people who are joining for the very first time. So we meet here every Sunday, 8 p.m., just like today. And this discussion and presenting is not limited to certain people. So anyone who has an interesting case that you think we can learn a thing or two from, you are very welcome to reach out either to me or Joseph, and then we'll leave the space wide open for you to share the case. And we are in desperate need for discussants, because we want to learn from other people also. So what I'm increasingly seeing is that my thinking and Joseph's thinking is becoming very uniform, because uh, so there are some things that I mentioned, and then on the next slide you see that Joseph's thoughts are almost the same. So we want to hear from other people. So we'll be very happy if new people volunteer to discuss. You can pick anyone to discuss alongside, or if you're comfortable enough, you can also discuss yourself. But also the chat in the WhatsApp group is open, so anyone can send messages. So if you have any reflections to share based on today's case, on any case that we discuss, you can also share in the group. But our contacts are also in the group. We are two admins there, so if you have a case to present, you can reach out through WhatsApp or any other means, so we can schedule for you to present or discuss your case. So having said that, thank you very much everyone for joining, and have a good night, and see you next Sunday.
Good night.